Okay. Good
Hello,
morning,
can you?
another time for Naples. The second case we are trying to treat is a 1-year-old female with Down syndrome with a moderate to large arterial duct, resulting in left volume overload and heart failure, that is in treatment with diuretic therapy. She is 7.5 kilograms. Next one. And at the echocardiogram shows a quite large arterial duct with a moderate pressure, pulmonary arterial pressure, with a transductal gradient around 50. Next one. This is the fixed echocardiographic picture of the arterial duct. The intended treatment is using a ADO 2 AS if it's possible. At cardiac catheterization, pulmonary artery pressure was quite high, with a mean pulmonary artery pressure of 28. The aortic pressure ratio is around
Laterale.
0.5.
Lateral.
This is the angiographic appearance of the arterial duct with a significant opacification of the pulmonary artery. We cross the arterial duct from the arterial side and try to put in this conical arterial duct a ADO to AS 5 mm, 2 mm long device. This procedure will be performed by my colleague Giampiero Gaio.
Okay.
Right.
So now
looking at the angios, this is quite a large duct with a very good ampulla. Who in the audience would use an ADO2AS?
We are concerned about the idea of using this device in order to go by the arterial side, and in other times it worked well like this. So we are sure that also in this case can be a good solution. Then we will try to put, we will perform a control angio, and if we are not happy about the result, we will try with another strategy.
All right, so while you're doing that, we'll ask the audience to hold up your hands. How many would use just the standard ADO for this procedure? Probably 90% of the hands are up, which we on the panel agree with. The ADO2AS obviously was designed for small ductuses and small children, and this patient is neither. It's not small, they're not small, and that's not a small PDA. The ADO was obviously designed for exactly this kind of duct. The AVP2 has been very helpful in type C PDAs that are elongated, that are long enough and tubular. So I guess most everyone in the audience feels that they would normally just put an ADO in this, not an ADO 2 AS that was really designed for preemies and some small children, and really is probably not going to be big enough to take care of this problem.
Yeah, in this case, as you can see in the angio, the smaller part of the PDA is around 2.5 millimeters. So a 5 millimeter large ADO2AS should be enough to close. Okay, so now we are going to put the device.
Un po' più dietro.
Okay. Now we will open the first disc. Yeah, like this. Okay, the disc is open. Now I will
Sorry.
go back with all.
Do you do biplane fluoroscopy?
Do you see the fluoroscopy?
Yeah, I wonder whether it's biplane simultaneous fluoroscopy. Your brain must be huge to
Okay.
Vai più vicino così
Integrate
facciamo
that.
un raggio di controllo.
Okay, this is the final position. Now we will perform a control angio in order to
Avvicinati.
see the position.
Devi chiudere.
I will put near the delivery system. Okay.
So, just looking at the device and the configuration, I would predict that the middle waist of that is on the aortic ampulla side, not in the narrowing.
Yes, our idea was to put one disc on the pulmonary side and the other two discs in the ampulla. What we would like to. Yeah, like this. What do you think? Do you like?
I'd like it better if it was an ADO, but it probably will work. This is, the intent of the way this device was designed. As you can see, the disc is relatively small and doesn't fill the ampulla, nor does the waist of the balloon, nor does the disc. And so, this is, again, this particular device was designed for the small child with a PDA where the middle fits into where the narrowing is. So, but it'll
We are
probably work.
quite happy about the final result. There is a residual shunt, but it seems inside the device, as usual with the 802AS, there is always a residual shunt across the device that will usually disappear after 24 hours.
Now, so you don't distinguish if you see a jet, and of course, what we look at typically, not just a jet, but is there flow around the device in the ampulla, which, because it doesn't fill the ampulla, which obviously there will be flow around it in the ampulla because it's much smaller. We have someone in the audience that's going to make a comment.
Hi, Aphrodite Ziha from Athens. I'm just wondering whether this duct might have been in spasm when you did your angiogram, because you said it's 2.5 millimeters at the narrowest end, whereas this child is actually failing to thrive. At 1 year, he's 7.5 kilos, and the echo showed a larger PAN, I thought. So just before you release, I might reconsider that unless you're certain it wasn't spasm.
Yeah, so you're making a comment that maybe there's spasm of the duct before they...
Yes, I think with
Yes.
2.5 millimeter duct, this child might not be failing to thrive so much. And because the tubular ducts do have a tendency to go into spasm, I think we just need to confirm. It may not be, it just came as an idea.
Yeah, so did you understand that? So in our institution, we do not put a catheter up into the pulmonary artery until the angiogram is done. We don't touch the duct until the angiogram is done, and then we make a decision. But so that, did you hear the question? Was there manipulation in the pulmonary artery or somewhere close to the ductus before the angiogram was performed?
So you suggest to perform an angiogram from the pulmonary artery, right?
No. No, the question came up. The configuration of the duct, which is a type A conical duct that you showed us the nice angiogram with the big ampulla and the narrowing at the pulmonary entrance, was there catheter manipulation, right-sided hemodynamic study, before you took the angiogram that could have potentially, the catheter touched the ductus, caused spasm, so by the time you did your angiogram, that wasn't the original configuration of the PDA. They're trying to justify a patient that has failure to thrive and etc., with just the duct that's 2.5 millimeters. So that was the question.
Yeah.
Could there have been spasm?
But we are quite happy about the result. So we would like to release the device and
see what's
see the final result.
Yeah, No, just release then, and we have to switch over to
Yeah.
San Donato
Yeah,
very
if
quickly.
you're happy with it, go ahead and release it, and
Okay.
then San
On
Donato
the
will
floor
be
of
ready.
single plane.
We are going to release. Yeah, released. The device seems in position. Now we will
And then you want to
perform.
give us a very quick angiogram, and then we'll go to San
Yeah.
Donato.
Now we will perform the control angio. Just a moment, we are going to perform the angio. Okay. Okay, in our opinion, the position seems very good with one disc on the pulmonary side and the two discs in the ampulla. There is a mild residual shunt, but in our experience, as I told you, this will disappear within 24 hours.
Okay, you'll have to report back to us later after 24 hours and see it, and tell us that the echo is closed.
Okay,
But we're going to thank you very much, and we'll go to San Donato next.
okay, thank you, bye bye.
Controlliamo solo un'altra volta.
Okay, guys. Jim Franco. Oliver, Giacomo, and myself are here, John, and the audience is waiting for you to tell us what you're going to do.